Welcome to the Deep Dive. Today, we're really getting into something you'll see a lot in practice. Anxiety, obsessive, compulsive, and related disorders.
Absolutely. These are incredibly common.
And for you listening, especially if you're a nursing student, getting a solid handle on these conditions is, well, it's fundamental for providing truly effective care.
Exactly. It's more than just textbook knowledge. It's about recognizing these patterns in real people and knowing how to help.
So for this deep dive, we've really been digging into the chapter on these disorders from Davis Advantage for Psychiatric Mental Health Nursing.
A great resource.
Our mission here is pretty straightforward. Pull out the crucial stuff for nursing. We're talking pathophysiology, signs and symptoms, and importantly, nursing care, interventions, and the treatments available.
Okay, let's start with the basics then, just making sure we're all on the same page with terminology. Anxiety itself, it's an emotional response, right, to a perceived threat.
Perceived threat, so not always something concrete.
Exactly. It can be vague, this feeling of unease, which makes it different from fear. Fear is also an emotional response, but usually to a known specific danger, like seeing a bear versus worrying about failing an exam.
Got it. Anxiety's the vague dread, fear's the specific, yikes, moment. What about obsessions and compulsions?
Okay, obsessions, these are thoughts. Intrusive, unwanted thoughts, urges, images. They cause a lot of anxiety.
And compulsions are the response to that.
Precisely. They're repetitive behaviors or even mental acts that someone feels driven to do to kind of neutralize the obsession or reduce the distress.
Okay. And panic.
Panic is that sudden, overwhelming wave of intense fear. Really intense, comes out of nowhere sometimes.
Feels debilitating, I imagine.
It absolutely can be. And then phobias. These are those intense, irrational fears about specific things, spiders, heights, social situations, leading to avoidance.
That's a great set of definitions to start with. Now, how common are we talking? You said prevalent.
Very. Anxiety disorders are some of the most common psychiatric conditions diagnosed. And interestingly, the data consistently shows they're more prevalent in females.
That's a key demographic point for nurses to keep in mind.
Definitely. And while we have these formal diagnoses now, it's not like these experiences are new. Descriptions matching anxiety pop up throughout history. We're just maybe better at naming and understanding them now.
Right. We've developed the language and the framework. Okay, let's get into the why, the neurobiology, what's going on inside.
This is where it gets really interesting. We often see imbalances in key neurotransmitters. Think chemicals in the brain.
Okay.
Specifically, often a decrease in serotonin and gamma-aminobutyric acid. Both of these usually have a calming effect.
Like the brain's brakes?
Sort of, yeah.
Hmm.
And conversely, you might see an increase in norepinephrine, which is heavily involved in the stress, fight, or flight response.
So less brake, more gas, essentially.
That's a simple way to put it, yeah. It disrupts the regulation.
What about brain structures? Are specific areas involved?
Oh, absolutely. Key players include the amygdala, that's like the brain's fear hub processing threats.
Mm-hmm.
In anxiety disorders, it can be hyperactive.
Overly sensitive to threat signals.
Exactly. Then there's the hippocampus, crucial for memory, including fear-related memories. The hypothalamus orchestrates the stress response, releasing hormones, activating the nervous system,
Okay.
and the frontal cortex. That's involved in appraisal, evaluating threats, regulating emotions, making rational decisions about danger.
Well, it's a whole network, really, not just one spot.
Precisely. And that ties into the transactional model. It's not just biology or just psychology or just environment.
It's the interplay.
Yes. It's the interaction between someone's biological makeup, genetics, neurochemistry, their psychological factors like coping styles, and the environmental stressors they face. That combination influences vulnerability.
That holistic view is so vital for nursing. We're caring for the whole person, not just a diagnosis.
Couldn't agree more.
Okay, let's dive into the specific types now. What do nursing students really need to be able to spot and know how to initially respond to? Maybe start with GAD.
Good starting point. Generalized anxiety disorder, GAD. The big thing here is excessive worry. Persistent, excessive worry about lots of different things.
Not just one thing.
Right. And it has to be happening more days than not for at least 6 months. And it's hard to control.
6 months. That sounds absolutely exhausting. What signs and symptoms might we see?
You'll often see restlessness, feeling keyed up or on edge, being easily fatigued, difficulty concentrating, like their mind goes blank, irritability, muscle tension.
Physical symptoms too, then?
Yes, definitely. And sleep disturbance is common trouble falling asleep, staying asleep, restless sleep. As a nurse, be aware that patients might come in complaining of headaches, stomach aches, muscle aches. these vague physical things can actually be the anxiety manifesting.
So we need to think beyond the immediate physical complaint, potentially.
Always. Consider the possibility of underlying anxiety.
Okay, GAD. Check. What's next? Panic disorder.
Yes, panic disorder, the defining feature. Recurrent, unexpected panic attack.
Unexpected is key there. And what does a panic attack actually look like, clinically speaking?
It's a sudden surge of intense fear or discomfort that peaks really fast, usually within minutes. And it comes with a cluster of symptoms.
Okay.
Things like heart palpitations, pounding heart, sweating, trembling, shortness of breath, or feeling like you're smothering, choking sensations, chest pain.
Sounds like a heart attack almost.
It can feel very much like one, which is terrifying. Also, nausea, dizziness, feeling unsteady or faint, chills or heat sensations, numbness or tingling,
Wow.
and psychologically feelings of unreality like derealization or being detached from yourself, depersonalization, fear of losing control or going crazy, and often a fear of dying.
That sounds incredibly frightening. So as a nurse, if someone's having a panic attack right there in front of you, what's the priority?
Stay with the patient, that's number one. Your calm presence is huge. Speak calmly, clearly, use simple sentences, reduce stimuli if you can, dim lights, less noise.
Keep the environment calm.
Exactly. And administer prescribed PRN anxiolytics, often benzodiazepines, if ordered. Then later, education becomes key, teaching about the attacks, coping strategies like breathing techniques.
Being that anchor in the storm, essentially.
Okay.
After panic, phobias.
Right. Phobic disorders. Remember, intense, irrational fear tied to something specific, leading to avoidance.
You mentioned different types.
Yeah, there's agoraphobia. That's the fear of situations where escape might be tough or help unavailable if panic hits. Think crowds, public transport, open spaces, and closed spaces.
So it can really limit someone's life.
Hugely. They can become homebound. Then social anxiety disorder, fear of social situations, scrutiny, negative judgment, and specific phobias, spiders, heights, needles, flying, you name it. Nursing-wise, understand the avoidance is central and impacts daily function.
Got it. Avoidance is a key feature. Now, OCD, obsessive compulsive disorder.
Yes, essential features here are the presence of obsessions, compulsions, or both.
We cover the definitions: intrusive thoughts, repetitive behaviors.
Right. And the key thing for diagnosis is that these are time-consuming, like taking up more than an hour a day, or they cause significant distress or impairment in life work, social life, relationships.
An hour a day, that's significant.
It really is. And the initial nursing approach, build rapport, be supportive, non-judgmental, but try not to reinforce the compulsions. Don't participate in the rituals, for example.
Tricky balance. Support without enabling the cycle.
Exactly. Now, related to OCD, we have body dysmorphic disorder, BDD.
What's the core issue there?
Preoccupation with perceived flaws in physical appearance. Flaws that others often don't see or think are minor, but for the individual, it causes immense distress.
So mirror checking, excessive grooming.
Yes, those repetitive behaviors or mental acts like constantly comparing themselves to others, nursing requires real sensitivity here to their distress, even if the flaw isn't obvious to you.
Okay. And trichotillomania.
That's the hair pulling disorder, recurrent pulling out of one's hair, leading to hair loss.
Is there a pattern to it?
Often, yes. Usually a feeling of tension right before pulling or when trying to resist, and then a sense of relief or gratification after pulling.
So it serves a function, in a way.
It does, to regulate that tension. Nursing strategies often involve habit reversal therapy, making them aware of the behavior and teaching a competing response. Journaling helps identify triggers too. Substitution, like using a fidget toy.
Finding something else to do with their hands makes sense. What about hoarding disorder?
This is marked by persistent difficulty discarding possessions regardless of value. It leads to clutter that compromises living spaces and causes significant distress or impairment.
It's not just being messy.
No, far from it. There's often a strong emotional attachment to the items, making letting go incredibly painful. Nurses need to understand that complexity.
Right. And finally, substance or medical-induced anxiety.
Yeah, this is when anxiety symptoms, panic, obsessions, general anxiety are judged to be a direct physiological result of using a substance, drugs, medication, or a medical condition.
Like hyperthyroidism.
That's a classic example mentioned in our source. So as nurses, a thorough assessment is crucial. You need that substance use history, medication list, medical history, rule out or identify these potential organic causes.
Which underscores the importance of good assessment skills overall. Speaking of which, How do nurses specifically assess for these disorders?
Well, it starts with a comprehensive psychiatric history, really digging into the onset, duration, severity of symptoms, asking about obsessions, compulsions, avoidance. Using standardized scales can help quantify severity too, like the Hamilton Anxiety Rating Scale, the HMA, or the Beck Anxiety
Yeah,
Inventory.
measures.
Right. And assessing triggers is vital. What makes it worse? Also, how does it impact their life? What coping mechanisms are they using now? Are they helpful or not? And always screen for co-occurring conditions like depression or substance use.
Okay, so based on all that data, what kind of nursing diagnoses might we formulate?
You'll see things like anxiety, obviously, which you can specify the level of severe, panic. Powerlessness is common. Fear, related to phobias perhaps. Social isolation. Ineffective coping is a big one.
Makes sense.
Disturbed body image for BDD. And ineffective impulse control, relevant for trichotillomania or maybe even hoarding.
Okay, so we have the assessment, the diagnosis. What are we aiming for? What do positive outcomes look like?
We want the patient to gain more control. So outcomes might be the patient recognizes early signs of anxiety and uses coping strategies. Or the patient can face anxiety-provoking situations without resorting to rituals or complete avoidance.
More functional coping.
Exactly. Expressing a more realistic body image in BDD, refraining from hair pulling or compulsive behaviors, ultimately improved functioning and quality of life.
Tangible goals. Now, interventions. We touched on panic here. Can we flesh out the nursing actions more?
Definitely. For panic, reiterate. Stay with them. Calm voice, simple directions, low stimuli environment. Administer those PRN anxiolytics like lorazepam or alprazolam if ordered. And after the panic, teach and reinforce relaxation techniques, deep breathing, progressive muscle relaxation. Empower them for next time.
Proactive education. What about for OCD? What are specific nursing actions?
For OCD, key thing. Avoid reinforcing compulsions. Don't participate. Gently work with them, often in collaboration with the therapy team, to gradually limit time for rituals. This is often part of exposure and response prevention, or ERP.
ERP.
Yeah, it's a core CBT technique for OCD. You expose the person to the trigger for their obsession, but help them resist performing the compulsion. It helps break that cycle. Also, focus on encouraging and teaching positive coping strategies for the anxiety.
Okay. And for phobias, we mentioned systematic desensitization and flooding. What's the nurse's role?
Primarily supportive and educational. Explain the therapies. Help manage anxiety during exposure exercises, which are usually led by a therapist. Reinforce their progress. Acknowledge how hard it is.
Be the coach and cheerleader.
Kind of, yeah. And for trichotillomania, back to habit reversal, nurses can really help with the awareness training, identifying triggers, patterns, helping them practice the competing response, clenching fists, sitting on hands, encouraging journaling, suggesting fidget toys. Practical stuff.
Very hands-on, collaborative work. Okay, let's shift gears slightly to treatment modalities overall. Medications seem key.
They often are, usually combined with therapy. SSRIs, selective serotonin reuptake inhibitors, are typically first line for many of these disorders. GAD, panic, OCD, phobias.
Like sertraline, fluoxetine.
Exactly. Those are common examples, though our source doesn't name specifics. They work by boosting serotonin.
What else is in the medication toolkit?
Benzodiazepines, lorazepam, alprazolam, clonazepam, mostly for short-term acute anxiety or panic relief. But there's that risk of dependence, so long-term use is generally discouraged.
Right, short-term only ideally.
Then there's buspirone. It's an anxiolytic, good for GAD, non-sedating, lower dependence risk than benzos. Beta blockers, like propranolol, can be really useful for performance anxiety, physical symptoms like racing heart.
Oh, interesting. For the physical side.
Yes. And specifically for OCD, clomipramine, an older tricyclic antidepressant, can be very effective, though sometimes has more side effects than SSRIs.
Okay.
And in tougher cases, you might see anticonvulsants, atypical antipsychotics, or mood stabilizers added to the mix.
Quite an arsenal.
Yeah.
Understanding these is crucial for medication administration and patient teaching. What about therapies? We mentioned CBT.
Cognitive behavioral therapy, CBT, is huge. It's about identifying and challenging those irrational, anxiety-provoking thoughts and learning adaptive coping skills. Very effective across the board for these conditions.
And the behavioral therapies we touched on.
Right. So systematic desensitization, that gradual exposure for phobias, implosion therapy, or flooding, more intense exposure. And ERP, exposure and response prevention, absolutely critical for OCD.
And habit reversal for trichotillomania.
Exactly. Plus, don't underestimate supportive psychotherapy. Just having that safe space to talk, process fears, get education and reassurance can be incredibly helpful.
It sounds like the best approach is often multimodal meds plus therapy.
Very often, yes. Tailored to the individual, of course.
Now, patient and family education, you mentioned it a few times. What are the absolute must-cover points for nurses?
Okay, key areas. First, explain the illness itself in plain language. What is anxiety? What is OCD? What are common symptoms? What's the typical course?
Demystify it.
Exactly. Second, medications. Purpose, dose, how to take it, potential side effects, importance of not stopping abruptly.
Medication adherence is key.
Absolutely. Third, teach practical coping techniques. Relaxation, deep breathing, mindfulness, exercise benefits. Give them tools for their toolbox.
Empowering self-management.
Precisely. Fourth, discuss triggers and how to manage them. And finally, resources. Support groups, credible websites, crisis lines. Connect them to ongoing support and educate the family, too, how to support effectively, what not to do, like inadvertently reinforcing rituals.
That comprehensive education piece feels so critical for long-term well-being.
It really is. Knowledge empowers patients and families to be active partners in care.
Well, this has been incredibly thorough. We've covered so much ground: the neurobiology, the different disorder presentations, the nursing process from assessment to intervention, and the various treatment options.
Yeah, and for all you nursing students listening, the big takeaways are: really grasp the why, the biological basis. Learn to recognize the diverse signs and symptoms, and know your interventions, both nursing actions and understanding the treatments like meds and therapies.
And always, always maintain that holistic view, incorporating patient and family education as a cornerstone of care.
Couldn't have said it better.
So, to leave you with something to think about, our listener and future nurse, given just how common these anxiety-related disorders are, how will you integrate everything we've discussed today into your own practice? How can you provide that truly patient-centered care and really empower people on their journey to well-being? Something to mull over as you move forward. Thanks for taking this deep dive with us.